Okay, let's start the hospital infection control workshop today. Sorry about it, and I'll try to cover those slides. Next, please. So, needle stick injury, as we know, it's an percutaneous injury from needle or from any other instrument contaminated with blood, body fluids, or other potentially infectious material is called as needle stick injury. Next. So the commonest causes are, as I told you, improper segregation, recapping of needles, transportation, reuse of needles, and bending of needles. Next. So what happens? This is the most important part I was taking here. If you expose to needle stick injury, then what will happen? So first aid would be wash off with soap and water. Don't encourage squeezing or putting up in your mouth. Just encourage bleeding. If you can squeeze it hard and try to see what is the mucous membrane, what is the depth of the injury, and you should be find what is the source from where this needle stick injury happened. Can we find out the source, because that will be the important contact point where what for the further treatment will be possible. Usually what happens is uh, I think Rohit, they're asking you to enlarge the screen. Reporting is nursing supervisor, ICNs, or anybody in your, if it is a small lab setup, you can tell the head manager or the lab manager, they can tell you. Then in emergency department, in our protocol, we go to emergency department. In a clinical area or in a clinical lab, what you can do is you can make a area where the everybody is your lab manager is able to see where the things are kept. So what he will do is he'll take out the form, and incident form must be there. I will share that incident form later. Full details, how the injury happened and what was the source. So patient details. Now, as I told you, patient's details are the most important point, because if we don't know what is the source of injury, we won't be able to further take any treatment. So it is important that your patient sample was it's available, you know which patient the prick is, or it is an unknown source. So if you're not able to track what is the patient's source, or what is the source of this needle, who had on which patient this is being used, you should be taking as an unknown source. Or if you know from which patient the medication was given at this point of time, so you can note the details of that patient. Then the other thing which is important is you should know the hepatitis immunization status of your own or the person who has happened to injury. So the first question you are going to ask is, what is the source of the injury, and is the source known or unknown? And the second thing you will be asking, what is the history of hepatitis immunization? So is the person immunized with hepatitis B immunization? And if yes, then how many years? And if no, then a part treatment will be different in that case. And if yes, then the part treatment is different. Or if yes, then what is the titers of that hepatitis immunization? Then what you do is you give your sample as well as the source. If the patient is known to you, you will take this patient sample also for HPV, HCV, and HIV, as well as for anti-HBs antigen and antibodies too. Then what we do is we always, for the treatment, from treatment point of view, we will see what we have to do, but report it and submit this. This needs to be seen in NABL also, in ISO 15189. It is an important way of tracking your needle stick injuries. So we should have an incident form where a needle stick injury is noted. Then you should keep it in a record file. If it is a hospital setup, you can inform the infection control nurse. If it is an emergency or a small department where you can help take a nurse help, you can also inform, or a lab technician can also do the incident. Yes, please. Next. Next slide. So investigations, now the time period following is very important, and this is scientifically based. Say these are the CDC guidelines, we call it, or even in a WHO guideline, how investigation of a needle stick injury should be followed. Usually what happens is people come to me and they tell that needle stick injury हो गया और बहुत घबरा जाते. They are very afraid. So there's no need to afraid, but what you do is you should have a follow up. So 0 weeks, so the day of injury, then 6 days, 12, and 24 weeks. So up to 3 months, you have to follow this case of a needle stick injury. Now, this is an important timeline. Why we say it that you have to follow for 6, 12, 12, 24 weeks? Because if the needle stick injury happened to be from a positive marker patient, say HIV positive, HPV, HCV, the patient, the sample in which we have taken might be in a window period. Window period means that no antibodies are detected in that period. But after full blown, after 3 weeks, usually the antibodies are formed, and we will be able to test that okay, the patient is suffering from HIV, HPV, HCV, both, none, or whatever. So the follow-up is the most important step I would like to emphasize here. Then all the healthcare staff, be it the nursing, be your technicians, they should be hepatitis B vaccination. Now everybody should know what is a hepatitis B vaccination schedule. So 3 dose series are given: dose 1, second on the 1 month, and third after 6 months, approximately 5 months after the first dose. So you would take a 6 months period. Then, and it is given intramuscular. That is the most important thing we should be looking at. Next, please. In our health setup, there are certain categories of immunization, and this is for occupational health hazards method. We can say this is important that we should be looking at immunization status. So usually the doctor should be nowadays hepatitis, influenza, as well as the COVID vaccination is given. In case of nursing, hepatitis, influenza, and chickenpox, all three should be given. Then microbiology staff, I would say, since I'm a microbiologist, meningococcal and typhoid vaccine, along with hepatitis B and influenza vaccine is important. Then paramedical technicians, hepatitis again and influenza. Then housekeeping GDs, if you have, or general duty assistant, you can have again hepatitis and influenza. Then F&B staff, where for a healthcare staff, a healthcare setup, it is important if you have stewards and those who are serving food to your patient or coming food, they should be vaccinated against typhoid. Then outsourced staff, maybe your housekeeping staff, they must be vaccinated with typhoid, as well as the these days tetanus and diphtheria, DT vaccine is given to the housekeeping staff. Dosage schedule, we know hepatitis B, I've already said. Influenza vaccine, it is given 1 dose annually. Then chickenpox given 2 doses. Second dose is after 4 to 8 weeks. Typhoid is usually given once in 3 years, and meningococcal given once in every year again for every dose. Next, please. Now, what should be the post-exposure prophylaxis for hepatitis B vaccination? So the post-exposure prophylaxis is, next, please. The post-exposure prophylaxis in needle stick injury, that is why I was saying the hepatitis vaccination state is important. So hepatitis, if vaccinated staff is there and antibody titers are more than 10 international unit, which is a norm, we need not to give any additional immunoglobulins in that case. So the person who has got needle stick injury, first thing to be asked is he vaccinated or not? If not, if not vaccinated, there's an immediate vaccine along with hepatitis immunoglobulins. That is what is required, and it should be given in a dose of 0.6 ml per intramuscularly. If the patient, if your healthcare staff is vaccinated but his antibody titers came out to be less than 10 international unit, what we must be doing is, if the patient is hepatitis negative, then give a booster dose. If the patient or the source of needle stick injury is unknown, we should give booster dose again. If the patient is hepatitis B positive, then we should be doing a complete series of hepatitis plus along with immunoglobulin should be given to that patient, to your healthcare staff. I hope this is clear because this is a most important slide. I've tried to put it in just one slide so that you are clear that if hepatitis C vaccination is your healthcare staff is vaccinated or not vaccinated. I hope it is very, very clear. If any questions, you can write it in the chat box. I will happy to answer. Next, please. So follow-up action is test exposed to hepatitis S antigen or antigen and anti-HBs levels. Decide on appropriate prophylaxis on the basis of algorithm. Repeat HBs antibodies for at 3 and 6 months, and a gastro reference is usually given because if the patient, if your healthcare staff just turn out to be having elevated levels of LFTs, then they need to be guarded in that case. So that is why we always suggest a gastro reference also. Next, please. If hepatitis C exposure happens, suppose if we come to know that hepatitis C is the source from which the hepatitis C was positive. Next, we will see an algorithm which can be defined. So there's no vaccination available for hepatitis C vaccine. So we know that. So what we will do is we will see anti-HBC titer. No active prophylaxis is available. Interferons are not recommended for prophylaxis, but what we can do is we can always test HCV RNA quantitative with LFT, KFT, CBC, and then repeat LFT after 4 weeks. This is a mandatory thing. These are the CDC guidelines that no interfere. People do come to us that if hepatitis C positive patient say prick ho gaya humko, so what we should be doing. So we should not be giving any interferons. It is not required. But what we should do is we should always test for HCV RNA quantitative also. Next. So test exposed to HCAs, HCV and baseline LFT. Again, this is happening at 0, 6, 12 and 24 weeks. All the time we will be doing this test at 0, 12, 24, 24 weeks. And this is a very costly affair. So we should be, the prevention is better than the giving the follow-ups. So if the source is anti-HCV positive or exposure, we should be having a baseline LFT. Consult an internal medicine, and anti-HCV GPT should be continuously follow up to these 6 months. That is what is the minimum period required for HCV positive needle stick injury case. Next, please. Now, this is again a very important post-exposure prophylaxis for HIV. I would like to tell. This is something, the transmission rate for HIV is just 0.03%, whereas for HCV it is 3%, for HBS it is 30%. So the more the exposure of a needle stick injury by HBS positive patient is much higher than compared to HIV positive patient. But the trauma, the emotional trauma which the healthcare staff gets if it is a prick from HIV positive patient, that is what we need to take care. Next, please. So post-exposure prophylaxis for HIV, it is immediate. It's a medical response that should be able to protect individuals which are exposed to HIV as soon as possible. The common side effects of post-exposure prophylaxis are many, so we should be careful whenever we are giving post-exposure prophylaxis. They mainly are anemia, nausea, peripheral neuropathy, neutropenia, and myopathy. And whenever we are giving any post-exposure prophylaxis for HCV. Okay, I'll do that. Once I complete, then you will be, I'll come back to HCV. Okay, I got your question. Next, please. So HIV prophylaxis, it is required. So usually a 2 dose is given. It could be a Viraday, that is efavirenz 600 milligram, along with tenofovir. That is again an anti-HPV HIV drug. It is given once a day, and the dose duration is 30 days. So usually what uh, post-exposure prophylaxis gives a lot of emotional trauma to healthcare staff. Along with that, a lot of gastritis issues, anemia issues, they do happen. And so that is why we recommend, along with efavirenz or Viraday, which is a combination of efavirenz 600 milligram, tenofovir, and imidazolpine, so 200 milligram. A domperidone or ramiprazole is usually given along with Vicasune. So this is a regime which is given for 30 days. Now, I would suggest whenever you're deciding on HIV prophylaxis, be a bit of more, don't be a complacent, but yes, you should thoroughly investigate what is the exposure code in this case, how deep is the exposure in this case, was it required in HIV prophylaxis or not. Next. So we know that safe needles, they are important and that should be so for saving lives. Next. I would like to go back to HCV, which she said that if you can explain it. Previous slide, before I go to spill management. Previous slide, previous to that, previous to that, previous to that, previous to that. Okay, so HCV prophylaxis, the question has come, can I explain it? So the chances of HCV is 3%. So whenever a needle stick injury happens, there's not a data available from outside, not much data available from Indian studies. But whatever the Indian studies say, usually hepatitis B positive, since the quantum of hepatitis B positive patient is higher and quantum of hepatitis C patients is much less, that is why the HCV case reported are only 3%. HIV is 0.3%, and that of hepatitis B is 30%. Now, clearing that data, whenever, because, next please, HCV does not have any, like hepatitis vaccination, there is no vaccination available for hepatitis C. So what will be the management? In case of hepatitis B, we have given immunoglobulins and we also give vaccination if the titer is less than 10. If not vaccinated, we will give the complete hepatitis B vaccination. But unlike case of hepatitis B, in hepatitis C, since we don't have any vaccination, what we are going to do is we are just tracking our healthcare staff in that case. So how we can track? We determine the source of hepatitis C. So the source of needle was from a hepatitis C positive patient. Now what we are going to do is from that patient, we will take blood, we'll get HCV RNA tested for that patient. HCV RNA, what it will give? It will give a viral load of that hepatitis C. Okay, and same way, what we will do is we will also take the patient's, the healthcare staff sample, whoever has got a needle stick injury. So we will take a patient sample. We will also take the person who got needle stick injury, and both anti-HCV RNA or HCV RNA will be sent for a reference lab, or if you have a lab, you will send this. Since no active prophylaxis is available, so no immunoglobulins are recommended in this case, not even interferons, because they have seen they will go and bind to a level where interferons HCV will not have much use. So in that case, we go for LFT, that is liver function test, we will go for kidney function test, we will go for CBC, complete hemogram, and this will be repeated after 4 weeks, 12 weeks, and 24 weeks. What we are doing in this case is we are just tracking that whoever got the needle stick injury, is he undergoing certain hepatitis? He might land up in hepatitis C or not. If the levels remain same, say LFT, KFT are not raised, we are sure that the the patient, the healthcare staff is not landing up in any hepatitis C group. So that is what is important to us. Got that? I hope I made myself very clear on hepatitis C. Any questions on that? Please do write in chat box. Okay, Divya. So I think it was fine. Then coming to one another important part of it, is HIV clear or should I explain it again? Because that is also again very important. What I would suggest is that this the way the people react to HIV needle stick injury gives a lot of trauma or a burden or an emotional aspect is there. If you are careful enough, and so it is a most preventable disease. And in our hospital setup, we did one of the study, and in last 5 years, we are able to, because of trainings and retrainings, we are able to reduce our needle stick injury data from, say, there were 80, 90 injuries, needle stick injuries happening in 1 year. We have come down to 12. So that's a good significant amount of number of cases when there is around more than 700 nurses, 300 housekeeping GDA staff, and technical, and so more than 3,000 employees. 100 needle stick injuries were also a big case. So we have reduced it to a much lesser level. And the only thing we did was training, retraining, unnecessary resources which were not there. We pulled up the resources and people were able to come out the data. Okay, so this is a true scenario which I'm telling, that retraining and training was hepatitis B prophylaxis paper ones. Okay, previous slides. Before that, no, 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 पीछे जाना है, पीछे वाली slides. Yeah, the first two slides she wants. Previous, specific to this, previous, previous to this, previous to this, previous to this. Yeah, this I think she needs to understand. That is why she asked for it. So what happens if hepatitis B? So we know 30% is the risk. Highest risk is with hepatitis B infection. Whenever a needle stick injury, the chances of getting hepatitis B is much higher than HIV or HCV. That is what I want to say when I think 3% or 30% or 0.3%. So the risk of hepatitis is 30%. And whenever an exposure happens, what we try to elucidate is whether the source, that means जहां से needle लगा है, needle किस patient का है, मेरा hepatitis B positive का है या hepatitis B negative का है, एक चीज. दूसरी जो चीज important है, whether the hepatitis C, my healthcare staff, suppose I got a needle stick injury, then the question asked is, मुझसे पूछा जाएगा, am I vaccinated? So if I'm vaccinated, the protocol will be different. If I'm not vaccinated, the protocol will be very different. So if it is so hepatitis, मैं कहूँगी I am vaccinated. But when my titers for hepatitis B are tested, if they come out into less than 10, there's another logarithm to follow. If it is more than 10, then you have to don't do anything. Just no additional, only additional tetanus is given. Otherwise, it's not required. Okay, this point is clear, I hope. If I'm vaccinated, but my titers are less than 10, that means I will require one booster dose for it. Okay, booster dose along with immunoglobulins. And if I'm not vaccinated at all, my titers came out to be 0. Immediately, within 48 hours, I say that you should get hepatitis B immunoglobulins, 0.6 ml per kg intramuscular. That is what is there. And it should be given after that immunoglobulins. You should always be given hepatitis B vaccination. That is what is required in this case. So HCV booster dose is always given. I hope this is clear to Deepa. Along with that, and again, this needs to be followed at 0, 6, 12 and 24 weeks. So every time we are going to test for hepatitis B status of ourselves, not the patient. We don't need to do anything with the patient. Next slide. Next slide. So we need to test our anti-HBs titer every 6, 12, 14 weeks. Okay. Repeat HBs positivity or the titers, are they increasing? If the booster dose are given, then their titers will increase. If the booster dose or immunoglobulins are given, nothing will happen. So immunoglobulins will give an immediate relief to hepatitis B against hepatitis B injury, and hepatitis B vaccination will give you a lifelong immunity. That is what we are trying to do here. I hope it's clear. Any questions? Great. So, and gastro reference like HCV, we have given a LFT, KFT needs to be done so that we can see the progress of our healthcare staff. Next, we'll come to the last part. Spill management I've included in this chapter because it's important and people don't teach spill management. So it is need to be usually a biomedical spill is there and we need to see those. Next. 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 So I have included just 2-3 slides in this. I wanted to teach minor and major spill management. Usually what happens, biomedical spill is called as major. Next please. And minor spills are in the laboratory status. Next. So categories of spill management, biomedical fluids, chemical spill, and cytotoxic. They are called as large spills. Whereas any blood, they are known as these small spills. Next. So in case of every lab, even in assessing when we go ISO 1589 says that every lab should have a spill kit. And every major nursing station, if you are in a healthcare center, you should have a spill kit. The spill kit contents are gown, cap, mask, gloves, gumboots. A lot of tissue papers should be available. If not, then newspapers can be available just to cover the spill. And whatever happens, we should have a ready sodium hypochlorite solution. You can make it fresh, or you can keep it in a container, and you can make it fresh as 1% hypochlorite solution. What you do is, first of all, whenever any spill happens, just cover that spill with tissue paper or a newspaper. Then you pour a sodium hypochlorite solution over it, and for 20 minutes, the soaking is so that extra spill happens, and we cover the spill with our 1% hypochlorite solution, and it remains there for 20 minutes. Once, why 20 minutes? Because 20 minutes the contact time of hypochlorite to kill any microorganism which is in the blood. So be it any viral marker, be it any organism, it will kill everything if a 20 minutes contact time is period. You just have to take the trash wearing all PPEs, put it in a yellow bag, and wash the area with soap and water. This was what I wanted to take up as additional thing so that people are aware. Usually when we go in different labs, people are not aware how to manage spills. Okay, next. In case of large spills, you can call a large major where you can have a central number where sand, the whole spill kit, a major spill kit will have a absorbent paper, sand, various acids and alkalis because the labs have it. So you should have antidotes of acids or alkalis, whichever you are using in lab or healthcare theater. And again, after that chemical spill, you should be cleaning the area again with the method I've told, sodium hypochlorite solution, wash it and clean it with water.